Hello, welcome to the Toolbox webinar, the webinar of the Toolbox for care for the small and sick newborn. Next slide. The goal of this series is to encourage the collaborative learning of for new small and newborn, sick newborn in humanitarian context of please come to the toolbox for newborn to be informed of webinars, news, and share tools and ideas. Please scan the QR code at the bottom of the screen to join the community. Next slide. We have a few upcoming events on July 30. We have the first next step for nurses for neonatal world nurses, personnel, governance, and qualifications for small and low income countries. And 6th of August, why is maternal milk even more important for more vulnerable babies?
Join the English channel, and you'll be able to listen to the webinar in English.
Next slide, I will introduce Dr. Our moderator today, Dr. Frank Hunjaunde, a pediatrician specialized in nutrition with 12 years of experience in clinical practice, research, and managing of projects in developing countries. Right now, he is a technical counselor with the OMS, and he leads the project, which is in the Central African Republic. Welcome, Dr. Frank. Thank you, Lauren, Allison, for your introduction. Ladies and gentlemen, good morning, good afternoon. It's my good pleasure to lead this webinar, which will focus on newborn health in humanitarian context, since we know that no country can be left behind. If we can all reach the sustainable goals, we will be focusing on newborn health in humanitarian context. Our first presenter will be Dr. Maria José Palma. Maria José Sanchez Alva is a pediatrician specializing in pediatrician. She studied medicine at the National Institute of Mexico. She works in intensive care, in neonatal care, and medical emergency medical care. She took care of vulnerable populations, newborn and children in Mexico, and while focusing on malnutrition and transmissible disease. She worked with Médecins Sans Frontières in South Sudan and working with for the development of the London School of Hygiene in London. Dr. Marie-José Sanchez is going to talk to us in about 10 minutes to give us an overall view on newborn care and health in the humanitarian context. Marie-José, you have the floor. Thank you so much, and hello, everybody. I'm happy to be here today. Next diapo, please. Next slide, please. Let's start by to remember the 3.2 sustainable goals, which wants to reduce close to 1.2 unfortunately, 64 countries will be lacking in this goal and 1.2 million of premature newborn were estimated to have been born in the 10 most fragile countries touched by humanitarian crisis. Born too soon, 2020. Humanitarian context is where a generalized threat to life and to health exists, which goes beyond the country capacity to respond. It could be a natural catastrophe, an emergency, public crisis in red and orange on the map. You can see that most of these countries are located in Africa and South Asia, and they necessitate 100 times more efforts to reach the sustainable goals. Here you can see the mortality rate in the 10 most vulnerable countries in 2002, according to the index. You can see Somalia, South Sudan, Yemen, with more 37,000 live birth, and you can see the SDGs 3.2 for this country. Also very important to say that the recent global events will change this geography because it is lacking the recent crisis. Can we face this problem? For instance, here you have a guy that gives you a health point of view. The first two, newborn health in humanitarian setting, is to the left, and roadmap to accelerate progress was put in together in collaboration with UNICEF, and the third is the guide for the HCR. These are key actions aimed at healthcare workers and for evaluation of health in humanitarian contexts. The main goal is to speed up health for each newborn in every context, and to ensure that all countries have their emergency plan in place to be deployed in case of an emergency. You can find all this information online free of charge. Next. Real quickly, we will speak a little bit of the various levels of care available for essential care for newborn. You have thermal health care, skin-to-skin contact, kangaroo mother care, support with breathing, exclusive breastfeeding, and signs of dangers, and these are first level care signs. Most of the countries are able to provide essential care to newborn. Next. South Sudan is a country that's only able to give first level of care to newborn, and in 2022, according to UNICEF, South Sudan had 40 neonatal death for 1,000 live birth, and this is a very huge effort is needed to reach the 2013 goal. In order to treat small and sick newborn, care is not possible, unfortunately. Next slide. For Syria and Palestine, you have 11 deaths of a neonatal for 1,000 births, and 9 deaths for 1,000 births, live birth, according to the UNICEF. This level of care can treat sick newborn who need more complex and specialized interventions, such as septicemia and breath issues. Compared to South Sudan, these countries have more higher basic care. We know that the situation in Israel and in Gaza, and we'll have info on that level at the later time. When you talk about the humanitarian crisis, you have the acute and emergency level, and we have the recovery level. During the emergency phase, the goal is to reduce excessive mortality. For that reason, it's very important to measure every birth and every death. If you use, for instance, cooking refugee in Bangladesh during the acute phase in 2017, you had 27 deaths per 1,000 live birth and 15.2 stillbirth for 1,000 birth. The people still need a continuous humanitarian response. We have during the recovery phase to where the goal is to align with the SDGs effort. But you can imagine that since they live in refugee camps, which are overpopulated, and the capacity and humanitarian resource necessary, and so they will be secure. In spite of thanks to the international collaboration, you have a lot of mobile clinics for newborn care, but they need more complex and sustainable services and additional resources. As a conclusion, whatever the context, the goal should be to give at least a second level type of care to newborn if we really want to reach the 3.2 SDGs. This is the specialized medical team, also the wise, the doulas, and the technological team. And so, as you can see here, but prior to that, we need to go on and work. So to be able to answer to the need of small and sick newborn. Thank you. Thank you, Dr. José, Maria José Sanchez. During the intervention, you reminded us of statistical data as far as humanitarian crisis settings in newborn and the premature death is in the most vulnerable countries in the world. And you reminded us of the context in humanitarian settings and that we just need the first level care. And so we can reach the next level. And then you're gonna remember the various humanitarian crisis phase, the emergency, acute, and recovery phases. It's important to monitor both. So we need to reach the next level by reaching out to the medical body and the engineering staff. And thank you very much for this. Now we have Zeina Jamaluddine, qui est basée à la London School of Hygiene and Tropical Medicine, nutrition. She's a nutritionist, epidemiologist, and researcher among refugees and marginalized populations. For also the other refugees using medical records. She's going to talk about neonatal mortality in Gaza. Thank you very much. I will talk for the projection in Gaza for next slide. since before the war started by Gaza. There was good level of care with reduced levels of maternal and newborn care. 96% of women were had 4 consultations minimum prenatal and were delivering in the hospital, and they were 22% and they were rather roughly 800, 900 babies per month, which needed emergency neonatal care. In December 2023, with attack to hospitals, a lot of women could not deliver in hospitals, and the medicine was also going down during the month of December, and the attack on hospitals and lack of fuel endangered premature babies' health. At least 5 premature babies over 37 were dead for lack of fuel. Next slide. In this context that we decided to project the impact of the war started by Hamas, it was possible to estimate this thing. By reduction of the access to care, we decided to project the impact of war on the mortality of various diseases, transmittable disease and non-transmittable disease. And we used 3 scenarios to project mortality, started with February, and to see how the situation was going to go worse. Second scenario is status quo that we saw mid-October and mid-January, and the escalation of war. The event to form the scenario was atrocity of war and the humanitarian space. Next slide, please. We used the LifeSafe tool, which is used to show how the increase to care, curative care, lowers neonatal mortality caused by various reasons. Then we went the other way around. We reduced the intervention to primary access, care access, and breastfeeding and access to hospital to document how many newborn were dying in each of these scenarios. For each intervention, prenatal care, hospital delivery, and facility care, the number of access prior to the war was taken into account. Then we used the data in Gaza and UN report to reduce interventions and up the interventions. We did this for various indicators. Next slide, please. To reduce breastfeeding, we were based on previous war data in Gaza, Syria, and Iraq, and in 3 various scenarios. With a reduction of available tools. We were able to detail this in the next slides. In terms of results, I will focus on neonatal death, the graph at the center of the slide. the pre-war mortality. Then we added the excess mortality in 3 scenarios. In green, ceasefire. In blue, you have excessive specific mortality. In gray, mortality prior to the war. And during war, the mortality goes up. If you go look at the situation since the war from October to August, you can see mortality. And so with that, what we did projection for the 3 scenarios. In the escalation scenario, you see the level reached 1,000 newborn dead during the war. As you may know, the main neonatal death is the lack of access to hospital care, curative care, and breastfeeding care. Projections show where interventions which are important to save a baby's life during the war. These projections was led in a conservative manner for increase of food security. We could have increased food security. Since now the data show that the situation is even worse. Food safety has impacted the stillborn rather than the newborn. All the figures that I show now are the number of newborn deaths without excluding traumatic injury. We can also show death due to traumatic injury. For newborn, the traumatic injury are a higher contributor for pregnant women than for newborn, but the mortality rate among live birth are higher, as Maria said, during the war. If you compare levels that we have in the status quo and the escalation in the previous Palestine levels observed in 2006 and 1980 in Palestine, health levels in neonatal mortality observed to 20 to 30 years ago. So the war impacted on neonatal death because hospitals do not work. And key interventions are access to medicine, care, and breastfeeding. Thanks. Thank you, Ms. Zeina, for your presentation, which showed us how the war has an impact on this country, and you showed us the factors for the neonatal mortality and showing us various scenarios. So excessive death due to traumatic injury and non-traumatic injury. And now we're gonna go to our third presentation with Dr. Johanna Thomson, pediatrician, counselor based in Paris, originally from Australia. And since 2011, she's been worked with Médecins Sans Frontières at various levels and led the implementation of training programs of Médecins Sans Frontières. Currently, she is a counselor on pediatric care for the MSF Academy for Healthcare. Aiming to increase technical abilities for teams working in limited capacities establishments. Dr. Johanna Thomson, you have the floor. Thank you so much for the introduction. I'm going to speak very quickly of our work for newborn at MSF or Médecins Sans Frontières. So the pedagogical or educational approach is based on the inverse class. This is a training where you have in two parts of the class. In the traditional class, you have the theory led by the professor, but with the participant, a lecture, and then you have the homework and activities for students to do home. In the inverse classroom, you do the inverse thing, as the theoretical side is led prior to the class work, and the activity and the homework is done in the situation of the classroom. So the training is more active with the teacher. This training is based on three various training phases. You have online training, autonomous, the first phase, and that's when the participants do everything at their own pace, and they can work autonomously and independently to do the theoretical part. So then that's for doctors, nurses, and midwives. Then vous donc, ceci est spécifique à la. This is specified to the profession based on case study. The third item is the technical training. For the first side, the online training, we have a training on our Tembo platform, which is open to everybody, not just to the MSF staff. We have modules available in French and in English, and here you have the serious bacterial infections. Then the participant can have access to the module, and it's on a systematic way, three various part of the training online. The three parts of the theory with the case studies, applied case studies, and assessment section to validate the birth prior to go to the classroom. Push next slide. This is an example of the theoretical part. Donc, you have here the hotspot. So the participant can see the clinical. They have the case study, they do the theoretical issue, and then they implement what they learned. We try to use the same tools they have there quickly. And then you have the explanation as far as the case study. Second training phase is a virtual classroom. The first training that we implemented was in South Sudan. And the example of a virtual classroom where we regrouped 8 various different projects. It was a practical exchange of experiences around case studies. And so they really worked on concrete cases to implement and practice their knowledge. There I am teaching a virtual class. The third part is of the training is training during work settings, and we have recommendations in the work to put into practice the theory part. And so for each module, we developed uh, a network, so all of the information is regrouped on one page that can be used in the entire world. These are a reminder of the most important steps and items, action items. Désolé, sorry, I'm speaking too fast. Here's an example of clinical activities. Now they learn training to implement in the service, in the ward. There we go. Quickly, if you have questions, please go ahead and ask them at the end of the session. Thank you, Dr. Johanna, who just introduced the experience of the Médecins Sans Frontières with the inverse class. Thank you so much. We hope that the questions from the hospital will be understood. Now we think that of the next intervention, the next presentation from Dr. Sophie Jeannette. Dr. Sophie Jeannette is a pediatrician specializing in newborn care and neonatal and maternal health everywhere in the world. And she has a master's in international health and with a tropical concentration from the Oxford University. She brings a lot of experience in Africa, Asia, and the US, and also on an international level. Ever since 2019, Dr. Sophie Jeannette is a counselor for the Médecins Sans Frontières in Senegal. Dr. Sophie Janet is going to give us a presentation on development, implementation, and hybrid learning in the Médecins Sans Frontières experience. Dr. Janet, you have the floor. Next slide, please. So imagine fatigue comes to maternity after a big, long process, a lot of pain. She comes with a companion. The midwife doesn't speak her language and doesn't let her companion have access. Fatigue, her baby is born with they cut the umbilical cord and put him separately. Apparently the little child was doing well. Next slide. But if that child needed also medical care, specialized care because he was very small and sick, and he's sent in such a space where there's nobody to accompany him. And that's where fragmented and siloed care between children and mothers. This approach, fragmented approach, is fragments the mother-child couple and is a factor for neonatal death. This is the reason why with Médecins Sans Frontières, we're launching an initiative to change the current paradigm. We want to integrate the mother-baby couple with a multidisciplinary approach I want to show you the implementation of this pilot project. And I want to, prior to doing that, thank a lot of our entire care team on the field who is doing a fantastic job day to day. So the approach zero separation is based on the integration of maternal and neonatal care. What does this mean? That means that we care for the couple at every moment during their health process. We want for baby and mother health be covered when we take care of them, and diminish physical separation, which is systematic in every healthcare situation. We want to have for goal to diminish neonatal mortality and maternal health, because a lot of postpartum depression is rampant. So we are in Bobode, Burkina Faso. We had a big volume of maternal and neonatal volume, and half of the admissions are small weight babies or small babies. After the implementation of this, the story of the women delivering in Bobo is a bit different. They can be accompanied when they delivered. Skin to skin care at birth are complied with, and the mom can accompany the baby during the entire process. As you can see in the picture, there is care provided right after the birth, and mothers are not seen as visitors, but as key actors in the health of their newborn baby. We did a few things to implement this approach. Next. The first one is very, very important to understand the need and the points of view of the mothers and their families and their communities as far as deliveries, postnatal care, what are their needs, and how can we adapt our medical care to their needs to be really focused on people and give respectful care. We did a lot of focus groups, discussions, and intensive units, and we created multidisciplinary units to teach. Our training phase was huge because we had to train the maternity team to teach the zero separation and to improve care, and for neonatal care to train doctors to handle and take care of women and mothers, and to integrate. As you can see, various methods were used. At the bottom of the screen, you can see the picture. We also did key actors of the hospital and the staff to discuss what was zero separation for MSF, and the challenges and the solutions in case of implementation. Finally, we created new structures and new collaborations between neonatology. Everything had to go on because there were some challenges. So the challenges go on currently, and we can see how to improve team collaboration. But this first experience showed us that it is possible to improve the care for these children. So it's time to change the paradigm. We need integrate maternal and newborn care. It is essential to understand and integrate the needs and points of view of the patients and family and medical care. Finally, zero separation is a call to action for all of us to think over the care we give to the child mother couple because they deserve a much better care. Thank you. Thank you, Dr. Sophie Jeannette. I'm sorry because Sophie Jeannette showed the experience of Burkina Faso on the zero separation phase in Burkina Faso and how in this space with MSF this project was implemented and how they took into account the desires and the health needs of the patients. We will go on to the last presentation from Dr. Bernard Brice. Dr. Demfak Bernard Brice is from West Cameroon. He has a doctorate in medicine. He earned in 2019 in the University of Science, Technique and Science in Bamako in Mali. He worked as a project head and health project head for initiatives for development. And currently, he is in charge of neonatal health with the International Rescue Committee in Central African Republic. He's going to show us the efficiency and feasibility of the obstetric and neonatal emergency care in RCA. Thank you very much for the introduction. We did a study to understand as a reference the emergency care and complete emergency care in the context and humanitarian context. So we have a case. So we need to say that the Central African Republic has a neonatal mortality is estimated to 1,037 for children under 5 years old. So during the two last decades, we must say that efforts are very important to talk about neonatal health in the most affected countries affected by in the humanitarian context. Orientation ways can be perturbed due to distance, access to care and safety, which is another reason that could lead to a refusal of even providing services. This being said, there's very few information available in this context on the efficiency of the protocol of reference, on the efficiency and the best way to best answer to the needs of women, girls, and their babies. So to be able to bridge this gap that we have provided this type of information. Next slide, please. So the general goal of this study is to talk about our experiences and practices of care for the reference process of SONUB at SONUG, and to document experiences and points of view as far as care research and references, and for women, girls, and to who looked for care in facilities. We also, it was a matter for us to describe the experience and points of view for care for the reference system, to identify barriers to the care to women and girls who had obstetrical complications and with small and sick newborn in SONUB and SONUC facilities. We had a few themes, especially human resources, decision factors, experience, feedback, functionality of the reference system, respect and preservation of the dignity in healthcare. Next slide. This study was done in 3 health districts in Central African Republic, in Pokarakakui, in Longpende Prefecture in the northwest of the country, and Nana Gribizi health sector in Anobomu in the same prefecture in southwest of the country. In these 3 health districts, we established 11 healthcare facility and 8 SONUC. We worked with health care givers and women and girls using and not using this reference system. We did interviews, semi-structured interviews, guided by interview guides and use of dictaphones and edited transcription material. A data analysis was done by the DEDUS program, and we defined thematic areas based on WHO quality standards. Next. So first of all, right away, we need to say that the time that was allotted to us didn't give us much time, so we chose a few preliminary key results. As far as care, healthcare, we looked at the availability of the network and of means of communication. And you could see that as for when the telephone network and communication means were available, communication established before and after the reference, and at the release of the reference hospital. Another important item which is important to note is that in the area where you have performances which are implemented, and you have a partner which has a health training, there's more effort given to the reference, and in most of the cases there was no complications between the 2 care. And when there was no telephone network and there was a lack of communication, in that case the reference file was written in the health report of the users. In that context, there is no preparation prior to the arrival, but it was reported of cases where a complication was happening. The team was supposed to do a C-cut, and it didn't happen because with a great impact of the reference case. Another aspect that we went into is the perception of the care quality by the users. The most of girls and women interviewed affirmed that the care quality essential care quality is good due to a qualified team and availability of medicine and of the technical infrastructure. We also explored, however, I would say that some participants thought that the care quality was poor, especially in basic care facilities, and due to the lack of care during transportation. On that level, they talked about the personnel was not qualified and not available even. And there was no availability of medicine and of technical infrastructure. So we also the transportation means in most cases there is only one reference facility, and in case when there is a few reference facilities, the factors taken into account are care, transportation items, the quality of healthcare by the qualified team, and availability of medicine and of the technical infrastructure, and especially geographical and access in the reference hospital. Another aspect on this item that we explored is transportation means use. In most references come via motorcycle and then bicycle, then by foot, walking, walking 10 kilometers, and an ambulance was not available, so not adequate means of transportations, and you had non-assisted delivery during the commute to the hospital. Next slide. As far as patients' experience, we do regarding the reference process and the system, the health system. In most cases, users did not feel respected because they felt that health caregivers did not communicate with them. They were insulted or had authoritarian and condescending behavior and verbal aggression, secretization, and bad behavior from the hair caregivers, humiliations of clients, and mistreatment. Care givers there was a lot of good communication on the other hand for other groups, and respect of clients, and a good welcoming. We had influencing factors. The most important is the transportation cost, safety on the way and the commute, lack of safety, bad weather conditions, the time, the illegal taxes on the way over, intimidation from the healthcare givers, and refuse. In most cases, prevented the reference. We don't have the users to justify refusing the reference to recommendations provided. Let's say that within the context of a volatile or fragile security, we want to give to the health care system means of transportation to facilitate reference and allow continuity of care during the reference, and also reinforce the capacity as far as personnel, medicine, and technical plate. This would allow to so we have to respect the community with the before, during, after delivery. And so we also have to adapt the healthcare agent. And the last recommendation is to train healthcare givers on communication techniques, social psychology, psychology of the sick person, the rights of the patient for respectful care, and modules on training in the healthcare system. Thank you very much. Thank you, Dr. Genfrak. We will share the experience of this study, and we will share your experience and the quality of the reference. We will now finish the first phase of this webinar. We will go to the next phase of questions and comments. So we will have an answer to Dr. Johanna answered one of the questions, and she posted the link of the cost of the Médecins Sans Frontières. A question from Tommy Camara from UNICEF. According to your experience and or your country, you have descriptions for maternal health in your preparation and the response to emergency preparation plan? If yes, which items should be in the plan? Is absolutely, for instance, the no zero separation orientation system. Thank you for the presentation. It's very inspiring. We only have 3 minutes. Alison, can you confirm? Si vous avez des questions, et après on s'y mettre les. We can put the questions after the webinar. I will answer. So I can answer for the Médecins Sans Frontières answer. So we've seen ever since the planification of activities. So this doesn't work because maternal health is separate from neonatal health. So I think that the implementation has to go hand in hand, and we think of the diet. We need to think of the couple and how to adapt. We need to plan and the transfer and to think of the couple and the taking into care. I would advise that the care has to be rethought because we already have a division in the system in general. Thank you, Dr. Sophie. This question is in English, but since this is a French-speaking webinar, I don't know what to do. Are there any other questions? S'il n'y a pas d'autres questions, et si vous voulez, les gens veulent ouvrir, if people want to open their mic and speak directly or just raise your hand. I think it's just a comment in English. So as far as care and for the care of twins for in the Ukraine war, with a positive result to avoid for the transport of newborn with a lot of success. This is somebody who shared her experience. Yeah, and you have to take care of newborn in humanitarian crisis. Thanks for sharing your experience. If I may go on this point, that's very important. Go ahead. In our experience, um, okay, something very important for the because all the time we don't allow people who accompany to go on. Too many people we can deal. But this is a huge thing because the mother cannot give kangaroo care. Somebody can help and can do a surrogate mother, and this was something very important that we saw in a lot of our projects. That's easy to implement. So we need to discuss with health personnel so that they may understand the benefits for this person accompanying who will support the mother-baby couple. Thank you, Nico. Thank you, Sophie. I think we will close the webinar now. Thank you. Thank you, everybody. The link is in the webinar, is available on the IUTL site. Thank you. It will be there in the next coming days. Thank you very much.